Welcome back to our Exam Revise podcast. Today's topic is the National Vector-Borne Disease Control Program, often shortened to NVBDCP. To set the stage, Dr. Joshi, what exactly sits under this umbrella?
The National Vector-Borne Disease Control Program is India's umbrella program for prevention and control of the major vector-borne diseases of public health importance: malaria, lymphatic filariasis, Japanese encephalitis, Kala-azar and dengue, with Chikungunya added as it re-emerged in epidemic form. The Directorate of NVBDCP provides planning, technical guidance, monitoring and evaluation. Implementation is through the states under the broader National Rural Health Mission.
So it truly is a one-roof approach. Before we dive into strategies, could you sketch the mission and high-level aims students should write in exams?
Certainly, the mission articulated early in the program was integrated accelerated action to reduce mortality from malaria, dengue and Japanese encephalitis by half, eliminate Kala-azar and eliminate lymphatic filariasis within specified timelines. That mission framed the 10th and 11th plan strategies: strengthening surveillance, human resources, behavior change communication, diagnostics and drug quality, and operational research.
Great. Now, examiners love frameworks. Dr. Joshi, what's the Core Strategic Triad?
Remember this three-pronged strategy. 1. Disease management. Early case detection and complete treatment, referral services, epidemic preparedness and rapid response. Second, integrated vector management or IVM. Indoor residual spray in high-risk areas, insecticide-treated bed nets, and long-lasting insecticidal nets, larvivorous fish, anti-larval measures, source reduction, and minor environmental engineering. And third, supportive interventions, behavior change communication, training, intersectoral coordination, and strong monitoring and evaluation. That's the backbone across the diseases.
Pause and recall. List those three pillars: disease management, IVM, supportive interventions.
To apply this, let's walk disease-wise, succinctly but exam-useful.
Please do.
Start with malaria, often the longest short note. For malaria, strategies emphasize surveillance with early diagnosis and complete treatment, plus IVM tools such as indoor residual spray and long-lasting insecticidal nets, or LLINS, anti-larval measures and epidemic preparedness. The National Strategic Action Plans have been iterated and refined through 2007 to 2022, but those pillars remain.
Quick case vignette. A sub-center in a forested block reports a spike in fever cases after rains. Rapid diagnostic tests show Plasmodium falciparum in multiple patients. What should the medical officer do step by step in the NVBDCP logic?
First, disease management. Confirm and treat all positives per national drug policy. Ensure complete treatment and track adherence. Triage for severe malaria and arrange timely referrals. Second, vector control. Organize focal indoor residual spray around index in neighboring households. Distribute or top up LLINs. Remove breeding sites and consider larval control where feasible. Third, supportive measures. Activate epidemic response, notify higher levels, and initiate behavior change communication on early care seeking, net use and personal protection. That maps directly to the program strategy.
Superb. Now, lymphatic filariasis. What are the program-level essentials students must reproduce?
Under the National Vector-Borne Disease Control Program, lymphatic filariasis control uses mass drug administration with DEC, sometimes with albendazole, plus morbidity management and disability prevention. It's one of the diseases targeted for elimination under the program's mission. For assessment, remember epidemiologic monitoring like microfilaria rate and clinical indicators.
Pause and recall. Name 2 program metrics for filariasis you'd mention in an exam answer.
Next, Japanese encephalitis. Control under the program includes strengthening sentinel surveillance, early diagnosis and proper case management at PHCs, CHCs and hospitals, behavior change communication, integrated vector control like fogging during outbreaks, spray spraying near animal shelters, larvivorous fish, anti-larval measures and vaccination of high-risk children in endemic areas.
And dengue and chikungunya, often clubbed in short notes?
Yes, both are Aedes borne, so source reduction is king. Weekly dry day, container management, solid waste control, plus personal protection. Program actions fall under the same triad: disease management, IVM and supportive interventions adapted to urban ecologies. The Directorate coordinates outbreak investigation, rapid response and risk communication.
What about Kala-azar? Any program-specific angle to remember?
Kala-azar, or visceral leishmaniasis, is vector-controlled via sandfly control and case management, fitting squarely within the same NVBDCP framework. Elimination timelines were part of national goals alongside lymphatic filariasis. Keep your answer aligned to the triad and note sandfly ecology to justify residual spraying and environmental measures.
I want to touch equity and geography. Dr. Joshi, how does the program focus on vulnerable areas?
The program emphasizes vulnerable groups, children, women, scheduled castes and scheduled tribes, and gives focused attention to tribally dominated hard-to-reach districts and the northeastern states, supplementing domestic funds with global partners in some phases. This is important both ethically and epidemiologically, as malaria burden is disproportionately high in such areas.
Let's bake in an exam-style analytical angle. Suppose a district posts a falling annual parasite incidence (API) but a constant annual blood examination rate (ABER) of around 10%. How would you interpret that?
If ABER is maintained, reflecting stable surveillance effort, a falling API suggests genuine reduction in malaria incidence, likely due to effective case management plus IVM. But if ABER had dipped, we'd worry about underdetection. INVIVA explicitly name both indicators and connect them to surveillance quality and program impact. These indicators are classically used to set targets and track malaria control.
Pause and reflect. How do API and ABER complement each other in monitoring?
Also remember the implementation architecture. The Union Ministry of Health and Family Welfare houses the Directorate of NVBDCP. States adapt plans, supervise and implement via districts, blocks and health facilities, with village-level workers supporting surveillance, IVM and behavior change communication. That phrasing, central technical guidance with state implementation, earns marks.
Could we do a second vignette to apply the triad beyond malaria?
Sure. Vignette. An urban ward reports clustering of dengue-like illness, fever, myalgia, retroorbital pain after unseasonal showers. Apply the triad. First, disease management. Triage and manage per clinical guidelines. Organize platelets cautiously by indication. Intensify laboratory confirmation and line listing. Then IVM. Urban source reduction. Containers, construction sites, space spraying around cases to knock down adult vectors, community-led weekly dry days and solid waste fixes. School drives for LLINs are less relevant here than for malaria, so emphasize container management. Lastly, supportive interventions, risk communication on warning signs and early care seeking. Intersectoral coordination with municipal bodies for water and waste, rapid response team activation. That alignment is exactly what evaluators expect for an outbreak short note.
Nice synthesis. Students also get asked about behavior change communication. What's the crisp, exam-ready line?
Behavior change communication supports net use, early care seeking, personal protection, repellents in clothing, and community actions like container management. It's listed as a supportive intervention across diseases and is integral to outbreak response as well as routine prevention. State that it's continuous, culturally tailored, and linked to surveillance feedback.
Any last golden point about surveillance?
Yes, strong surveillance underpins everything: early detection, trend monitoring, and timely response. The program framework, especially in the 11th plan period, explicitly stressed strengthening surveillance systems and quality assurance of diagnostics, which is a recurring exam theme.
To close, could you give a compact summary students can mirror in their final paragraph?
Certainly, right? The National Vector-Borne Disease Control Program integrates prevention and control of malaria, lymphatic filariasis, Japanese encephalitis, Kala-azar, Dengue, and Chikungunya under one national framework. Its three pillars are disease management, integrated vector management, and supportive interventions. Implementation is centrally guided, state-executed, with focused attention to vulnerable groups and high-burden geographies. Robust surveillance indicators like API and ABER help interpret trends and trigger response. Case management plus vector control and behavior change communication together drive impact.
Perfect. Pause and recall. List the 6 diseases under NVBDCP and then map each to one specific IVM action you'd write in an exam. That's your takeaway drill. Thanks, Dr. Joshi. This was tight, structured, and exam-ready.
My pleasure. Keep practicing those triads and vignettes. They mirror how the program works in the real world and how examiners think.